Let's discuss CSCR classification. When we look at the CSCR classification, there was actually a serious confusion, but I think the classification made by Chabliani and Behar-Cohen really solved this issue as much as possible. This is the best classification yet. In this system, the type formerly referred to as acute or classic is now labeled as simple. The type previously known as chronic is now referred to as complex, and in this context, we have a requirement of having an RPE change larger than 2 optic discs. Do you know where the biggest confusion happens? We face our greatest challenge and most significant confusion when naming persistent, recurrent, and chronic patients. These two patients have known about the disease for 7 months. Here, putting these two different patients into the same group while doing a scientific study causes study complexity because their treatment responses and visual prognoses differ. Furthermore, we encounter this same level of confusion when we are describing the patient. It is considered more precise to assess using a combination of multimodal imaging, especially autofluorescence, rather than relying solely on the patient's perceived date of disease onset. Here, instead of calling this patient chronic, calling it simple persistent and labeling our other patient as complex would be more accurate. Because not everyone is fully familiar with the terms simple and complex in this video, I will use acute to define simple cases. I will use chronic to define complex cases. Central serous chorioretinopathy may present as either unifocal or multifocal. Multifocal type is more common in Asian steroid users and chronic patients. When we look at the clinical course of central serous chorioretinopathy, 50% of acute patients recover spontaneously. Following spontaneous recovery, recurrence rates of up to 50% have been reported, and it has also been noted that 36% of these patients show a tendency to progress into a chronic form. Chronic complex patients present at a more advanced age. There is photoreceptor atrophy characterized by extensive areas of RPE atrophy and atrophy tracts. In these cases, we observe the serous retinal detachment to be shallow. You should not anticipate a very prominent serous detachment here. Spontaneous recovery is rare. How does this chronic disease form? Simple acute cases can turn chronic with persistence and recurrence. Without treatment, these patients develop severe chronic cystoid degeneration. Or, patients present directly with the chronic form. Patients often start with shallow symptoms of the disease in the acute phase, not realizing the severity of their condition. This delayed recognition hinders early treatment initiation. These patients live with persistent shallow fluid. It goes unnoticed. However, once photoreceptor atrophy occurs, individuals begin to notice this disease. Another form we see mimics pattern dystrophy, though you may not encounter it very often. This looks like pattern dystrophy in infrared reflectance and autofluorescence imaging. We diagnose these by seeing choroidal hyperpermeability in green angiography. These patients are also characterized with shallow fluid on OCT. They are often mistaken for pattern dystrophy. The bullous type typically exhibits significant leakage from multiple locations, frequently leading to mistaken identity with rhegmatogenous retinal detachment. When we examine the clinical features of central serous chorioretinopathy, we observe symptoms such as blurred vision, relative scotoma, metamorphopsia, micropsia, hypermetropization, and a decrease in contrast sensitivity. Yet in our extensive study, which is the largest case control series in the literature, we find that the number of asymptomatic patients is actually quite significant. 9% are asymptomatic at diagnosis. In second eyes, because we use wide-angle imaging, we see that the asymptomatic patient rate in the second eye is 63%. When we look in this study of ours, bilateral involvement is 42% and multifocal is 32%, but in chronic cases, bilaterality is 64% and multifocality is 51%. Let us look at disease imaging. The imaging method that we use most often here is optical coherence tomography. The most common finding we see here is pigment epithelial detachment. In our study, we reported it as 81%. Studies report pigment epithelial detachment between 53 and 100%. When we look at irregular PED, the situation we call irregular PED or flat irregular PED, I had mentioned that this is also referred to as double layer sign. I said it started to be said first in PCV. However, double layer sign does not mean anything on its own. Flat irregular PED on its own does not indicate choroidal or macular neovascularization. If the content is hyperreflective, it is avascular. If the content is hyperreflective, we state that there is a 50% probability of having macular neovascularization within it. Here you can see a flat irregular PED with content that is hyperreflective and avascular. In this case, there is a hyperreflective component and a macular neovascularization has truly formed within it. You can see here that the component is hyperreflective. We typically observe fibrin in chronic or bullous cases, where a hyperreflective deposit resembling vitelliform material develops. The space in the middle that appears hyperreflective is known as a vacuole, suggesting that ongoing active leakage is occurring in that area. Photoreceptor outer segment elongation appears in persistent patients, first like this. It takes this form, then it elongates like a brush border. Even in this condition, it should not be viewed as a sign of poor prognosis. The vision of these patients can improve if they are treated. However, if photoreceptor loss develops after this stage, which is to say photoreceptor atrophy, as seen in this patient, it is now a clear sign of a poor prognosis. Of patient vision, we can say that it will not improve. After OCT, the imaging method I use most frequently is autofluorescence imaging. Is the disease acute or chronic here? Are there multifocal or extrafocal spots? What is the visual prognosis? I can tell all of this by looking at autofluorescence. In acute simple patients, it does not show very clear findings at first. A mild shading or a masking effect may occur depending on the effect of the fluid. As photoreceptor elongation begins, autofluorescence increases in acute simple patients. In chronic complex patients, in the early stage of the patient, the lesion is more oval, and in more advanced cases, we observe autofluorescence changes in the form of downward tracks or gravitational tracks. Gravity and the patient's sleeping position can be influential in the formation of this shape. Why do these gravitational tracks occur? We take a horizontal section image and tell the patient, your fluid is decreasing. We say you're healing, but they aren't, because the fluid is shifting downwards, as you can see here. When we look at the patient's autofluorescence image, we observe an increase in hyperfluorescence from top to bottom. Here, the upper side is more hypo, the area with chronic fluid, and we see hyperfluorescence in the parts where new fluid comes. If these patients are not treated, an image like this may be formed. Fluorescein angiography is a frequently used imaging method. In acute patients, we have two leakage patterns. We can see the ink blot leakage pattern more often and the smokestack leakage pattern less often. In chronic complex cases, due to window defects, due to atrophy, it is not possible to understand where the patient is leaking, as you can see here. Indocyanin green angiography is truly very profound for us in this disease. Here, the mid-phase is 5 to 15 minutes for indocyanin green angiography. We see choroidal hyperpermeability here, as you can see. In the late phase, this can transform into a negative staining. Or, as we see in this specific patient, it can present as persistent hyperfluorescence. We can observe choroidal hyperpermeability as unifocal, multifocal, or diffuse. OCT angiography also became very valuable to us from the moment it came into use in central serous chorioretinopathy, because we saw that in chronic cases, neovascularization is present in up to 39%. It is very hard to detect this neovascularization with fluorescein angiography. The imaging method that shows this best is OCT angiography. OCT angiography also shows us choriocapillaris flow voids for academic research. However, in central serous chorioretinopathy, we see a false flow void due to the shading effect of the fluid you see here. We had developed an algorithm connected to MATLAB to eliminate this, and we used this algorithm in pachychoroid patients. The parameters we examined were maximum flow void area, average flow void area, and percentage of non-fluorescent choriocapillaris area. And here we observed that the maximum flow void area showed colocalization with pachyvessels and neovascularization. We studied pachychoroid pigment epitheliopathy, active central serous chorioretinopathy, spontaneously healing central serous chorioretinopathy, PDT-healed central serous chorioretinopathy, pachychoroid neovasculopathy, and controls. Here, the pachychoroid group is worse than the control group in all parameters. In other words, all parameters were found to be higher, which is worse. Pachychoroid neovasculopathy was the worst. However, interestingly, in only one parameter, no significant difference was found between PDT-healed central serous chorioretinopathy and controls. This was maximum flow void area. Our parameter that shows colocalization with pachychoroid neovasculopathy, neovascularizations, and pachyvessels did not differ in PDT-healed central serous chorioretinopathy and the control group. This was actually a finding contrary to what we expected, because what do we expect? Photodynamic therapy, PDT, causes choriocapillaris ischemia, but this knowledge of PDT comes from its use in age-related macular degeneration, where it had to be repeated and had to be performed at full dose, full time, and full fluence. The choroids of patients with age-related macular degeneration are thin, and these patients lack choroidal hyperpermeability. Pachychoroid patients are the opposite. They have thick choroids and choroidal hyperpermeability. Photodynamic therapy provides us with choroidal remodeling. Choroidal thickness decreases and choroidal hyperpermeability disappears. Naturally, the pressure that the Pachy vessels in the halar layer exert on the inner choroid also disappears, and choriocapillaris ischemia can decrease. I am not saying that patients treated with PDT have no risk of choriocapillaris ischemia, but it is quite low compared to age-related macular degeneration patients. Let's look at new findings. When viewed with wide-angle OCT, it was shown that the choroid is thicker than it should be, not only in the macula, not only in the fovea, but in the entire choroidal tissue between the vortex veins. Apart from this, it turned out with in-face OCT that there is asymmetric venous drainage. What does this mean? Normally, the choroid vessels taper off and terminate at the midline without crossing to the other side, meaning upper vessels do not cross to the lower half and lower vessels do not cross to the upper half. However, this is not the case in central serous chorioretinopathy patients. There is an asymmetric venous drainage and, as seen here, the vessels do terminate with tapering but cross to the other side. We can also see this with the choroidal vascular volume measurement in our new OCTs, as you can see here. The venous system coming from the lower side provides a very serious asymmetric venous drainage in these patients. We encounter vortex vein anastomoses in these patients. What does this mean? Normally, the vessels should have terminated when they reach the horizontal line, but in these patients, they do not. The upper vessels form an anastomosis with the lower ones, I mean the superior and inferior. You can see it here. This is from Matsumoto's paper. This is one of our patients. Here you can observe that the vortex vein anastomoses are formed by vessels originating from different systems. Ultra-wide-field indocyanine green angiography confirmed these findings for us. As you can see here, there is asymmetric venous drainage from the inferior temporal and superior nasal. We are also seeing intervortex anastomoses here. Vessels originating from two different systems have formed an anastomosis. And when we take all of these findings into consideration, Spade put forward the venous overload choroidopathy hypothesis. He stated that there was an overload in the vortex vein system, and when searching for the culprit, it occurred to him that the sclera might be to blame, because the vortex veins were emerging from the sclera in an oblique fashion. The first study by the Japanese Imanaga showed thick anterior sclera in central serous chorioretinopathy patients. Later, several more studies supporting this followed. And Spade also showed that the posterior and equatorial sclera are thicker in patients with central serous chorioretinopathy. It didn't end there. Spade showed this in 2015. There is fluid loculation in CSCR patients. What does this mean? There is fluid accumulation involving the choroidal vessels, or at the same level as the Haller's layer vessels in 67% of these patients. And again, Imanaga and colleagues showed that this fluid loculation is associated with thick sclera and thick choroid. At the same time, cilioretinal effusion also appears in these patients. Ciliochoroidal effusion also appears. We wrote it wrong here. This should be ciliochoroidal. We see this condition in about 2% of normal patients, but it appears in 20% of central serous retinopathy patients. This means there is a suprachoroidal fluid accumulation in these patients, which is linked to a thick sclera. So in these patients, the leakage from the choroid moves toward the retina on one side and toward the suprachoroidal space near the sclera on the other. And again, when Imanaga compared simple and complex patients, he saw that scleral thickness, ciliochoroidal effusion, and fluid loculation were in the complex group more prevalent. And scleral thickness emerged in this study as an independent risk factor for the development of complex CSCR. However, interestingly, the sclera was not found to be thick in cases of steroid-induced central serous chorioretinopathy. They proposed this pathophysiology table. As our genetic factors, scleral thickness, short axial length, and vortex asymmetry are present. Triggers are stress, steroids, and other factors. Depending on this, vortex vein congestion, extravascular leakage, and subretinal fluid accumulation occur. Reduced transscleral flow leads to choroidal and suprachoroidal fluid accumulation,